Hey everybody, this is Leila, Health Education Manager here at AiArthritis, and I am here to report back on day 2 of ACR. And I am in the exhibit hall at our booth right now, right before the exhibit hall opens. So I just wanted to film my debrief real quick and let you all know about the different sessions that I was able to attend yesterday. And so there are a variety of different topics. Also, just on the patient side of everything, I was not feeling too well yesterday. I think I was just really tired from lack of sleep and all of that kind of stuff. So I did decide to not go out with the team at night and just ended up staying in bed and relaxing. And I do feel a lot more refreshed and regenerated this morning. So I'm super excited to have our last day here at the conference. So I'm going to be talking about a few different topics. The first one is going to be talking about steroids in pediatric lupus and should these still be used? Should they not be used? Should they be tapered? And there are two doctors, Dr. Von Shaven and Dr. Brunner. And Dr. Von Shaven, coincidentally, actually was my pediatric rheumatologist at UCSF when I was first diagnosed with lupus when I was 12. She was actually my second rheumatologist there. But I think it's really cool that it's full circle that I was able to see one of her sessions. And her viewpoint was that chronic steroids, especially in such early childhood, can cause bone damage, short stature, mood changes, infection risk, and cardiovascular disease. And 60% of damage in lupus can come from steroid exposure. Evidence shows some patients maintain remission steroid free when tapered slowly and supported by medications like belimumab or mycophenolate. And the goal would be to be less than 5 milligrams a day or complete withdrawal when safe. And when I was a pediatric, I did have a lot of steroid use. Thankfully, did not have that much damage. I did have high blood sugar or like pre-diabetes when I was younger, and that could be attributed to a lot of the steroid use that I had to do. But once I was on medications like belimumab and MMF in my early 20s, I was able to taper off of prednisone very slowly. When I had lupus nephritis originally, I was on up to 80 milligrams of prednisone at a certain point, and I very slowly, about over a year and a half, was able to taper off. I think the less than 5 milligrams a day is standard when it comes to steroid use in general of the goal of what to do. And Dr. Brunner had the viewpoint that steroids are still needed. And especially when there's acute, huge flares, it saves lives. It helps bring down the inflammation as much as possible. There's no true replacement for that rapid inflammation control. So it does seem like it is pretty needed. Low doses, like 5 milligrams a day, can stabilize disease without any significant harm. And of course, there's no one size fit all to taper protocol. And I think that's the biggest takeaway is that you have to listen to your body when you are tapering off of steroids and have your doctor be a part of that conversation, of course, but definitely helping to lead your doctor in the way of how it's going to best benefit you to taper. And even if that means going down half a milligram every 2 weeks, half a milligram every month, whatever the slow taper is for your body, is going to be the best situation. And so the debate ended up somewhere in the middle where obviously high use of steroids is definitely for a prolonged amount of time is definitely not recommended, but it is still a way to bring down inflammation and help patients to make sure that they're not in a flare. Second topic that I just want to go over briefly was the reproductive health guidelines. There's a 5 year update. So basically, the guidelines are originally from 2020, and there's newer reproductive health guidelines that came from ULAR this year. And it has to do with all of the different types of medications. I'm going to go over a little bit more on each different type of medication and what is recommended now. TNF inhibitors like Enbrel, Humira, and Cimzia are safe through pregnancy and breastfeeding and no need for any type of switch. Non-TNFi biologics like rituximab, belimumab, or anything similar. There's growing data that show no major concerns, but should be individualized and should be a decision that's made by both the doctor and the patient to see what is best for that individual during that time of their disease and what their preference is. It's important to educate the mother on any risks that may happen if staying on those biologics, but there is minimal risk that is starting to show in the data. Rituximab can be used if needed for serious disease with minimal risk to the baby. NSAIDs or medications like, sorry, off the top of my head, I'm trying to remember, like naproxen or ibuprofen should be avoided after 28 weeks. And acetaminophen is still considered safe. A lot of people recommend avoiding NSAIDs overall, but if that's really needed to help control pain in disease, then it can be used up to 28 weeks. For Rho positive pregnancies with the risk of heart block, it's recommended to continue hydroxychloroquine, and ACR recommends a fetal echocardiogram every 2 weeks between week 16 to 26. I myself am not necessarily Rho positive, but I'm SSA, SSB positive. And so this is one of the protocol that I've had to follow in my pregnancy. I am going to be 26 weeks, or I am 26 weeks today. I am going to have my last fetal echocardiogram from week 16 to 20, or mine was week 14 to 26, but I'm having that last echocardiogram on Friday. I'm glad I don't have to go to the hospital every 2 weeks again, but it was really good to make sure that there was no risk of heart block happening with my pregnancy. Inactivated vaccines like flu, COVID, or Tdap are safe throughout pregnancy. Delay infant live vaccines for 6 months if exposed to TNFI in late pregnancy. And lastly, one of the things that they mentioned is birth control. Specifically, estrogen containing methods are unsafe for patients with antiphospholipid antibodies, and progestin only or IUD are preferred. So that is important to think about when thinking about birth control options, but it's also reproductive health, obviously, not just anything having to do with pregnancy. So obviously, there's a lot of decision making that has to do with medication when it comes to pregnancy. And mothers to be may have different preferences and different levels of understanding when it comes to what may happen to the baby when on different medications. So just making sure to coordinate with an OB, rheumatology, and maternal fetal medicine in order to make the right decision for you as an individual. Okay, next thing that I wanted to talk about is going to be Still's disease and MAS. So I went to a very scientific session and it was a little bit hard to follow, but Still's disease and MAS are really important topics with AI arthritis because we did inherit the International Still's Disease Foundation when they dissolved a few years back. And making sure that we are reporting back for Still's patients is really important to us since there aren't many different organizations that cover Still's. Basically, they were talking about cytokine overactivation, which is the mechanism that drives both Still's disease and macrophage activation syndrome. And these conditions are starting to become re-understood as a part of the inflammatory spectrum rather than autoimmune alone, which we identified that at AI arthritis for a while now. That's why we have autoinflammatory in our name, is because we cover autoinflammatory diseases, including Still's disease. And they had the different cytokines that are in the spotlight. These are basically used to help do the studies and the science to see what they can target in order to have medications that will help with bringing down all of the in these cytokines. And these specific cytokines, interleukin 1, 6, and 18, overproduction of these causes fever, rash, joint pain, and organ inflammation. And so they're looking at targeted biologics to block interleukin 1 and 18 to hopefully prevent severe mass or recurrent mass. If you're able to keep those cytokines at bay, then it's likely that they wouldn't have an overproduction if there's medications blocking those specific cytokines. And early detection and prompt cytokine blocking may prevent ICU admissions and organ damage. Now, when we hear different stories about people having MAS, it's very hard for the emergency room to identify what MAS is, even if the patient is letting them know that's what they think that they are going through. And so it's really important to have as many resources as you can to be able to bring to the emergency room. And so we do have a lot of very interesting resources on our website, both for Still's disease and MAS. I'll make sure that those are linked here in the email with all of our different debriefs. One is a Still's disease wallet card that is really important to be able to keep in your wallet in case anything happens to you, so that they can identify that you're a Still's disease patient. And even if the doctor doesn't know what that is, they can look at the card and see what types of tests that they can do to make sure that they can help take care of you. Same thing with MAS. We have both a patient guide and a healthcare provider brochure that you can make sure that you keep with you so that you can help yourself and your family members know what the signs are of MAS, and also bring these brochures with you to doctors so that they can get more information on what may be going on in your body, and especially just knowing how imminent and how important it is to get quick intervention, especially if you're already in a cytokine storm. The earlier the better, and the more damage that you can prevent. And yeah, just again, knowing the symptoms of MAS and what to test for is really important. High fevers is something that's really common. Confusion and also testing for ferritin levels is something that's really important. So those are the three different topics that I wanted to report back on. And I hope that these were very informative for you all. I'm super excited again to report back for you tomorrow. Again, if you have any questions, please feel free to reply to the email that has this debrief in it. Or if you are watching this on YouTube, go ahead and leave a comment for us. And we'll talk to you all soon, or I'll talk to you all soon. Okay, have a great day. Bye.